surgical therapy, we have to define better what's going on. And so we go over this, and they have to have had an endoscopy. An endoscopy is absolutely essential to make sure we understand where their disease exists, whether they have shortened esophagus from chronic scarring, whether they have strictures where things are blocked there, and again, to make sure that there's no underlying cancer.
Now, if there's a problem with the pump, what do you do? And if there...
So that's the most difficult problem, because if there's a true problem with the swallowing mechanism and the peristalsis of the esophagus, then the surgery down here is actually not going to be that helpful. Now, the most common problem that people have that cause significant reflux disease is a problem with the valve. And I'm sure you've heard about hiatal hernias.
Yes, common.
Common. So I tried to draw a picture of what a hiatal hernia represents. Now, so what I have here is, this is the esophagus, this is the diaphragm, and the stomach and lower part of the esophagus should all be below the diaphragm. A hiatal hernia is an enlargement of the opening of the diaphragm. So you have what I drew here is the hiatal hernia sac. So when you have a hiatal hernia, the junction of the esophagus and the stomach moves up into the chest. This does two things to exacerbate reflux. Number one, the junction of the esophagus and the stomach usually is in the abdomen, which is a positive pressure system. And so the positive pressure from the abdominal cavity allows the lower esophageal sphincter to be more competent. When you move the lower esophageal sphincter up to the chest is relative negative pressure. So you actually decrease the overall pressure in the lower esophageal sphincter, making this valve less competent. The other thing that happens that's very critical is that the angle, what's referred to as the angle of His in the normal anatomy, this angle here of the esophagus and the stomach, when you have a hiatal hernia, that angle is lost. And that geometry is very critical for the effectiveness of the lower esophageal sphincter.
So then do you create a new sphincter? What do you do?
So what we do, the most common operation that we do, is called a fundoplication. And so this is often referred to as a wrap, where you actually take the upper part of the stomach and you wrap it around the lower part of the esophagus.
Like right here.
Oh, right, exactly. You wrap it around, you sew it in the front here, and you retranspose the lower esophageal sphincter to be below the diaphragm. So it relocates the lower esophageal sphincter to be in the abdomen, and it takes the upper part of the stomach and wraps the lower part of the esophagus to help create more of a valve. This is called a fundoplication. The most common is referred to as a Nissen fundoplication. It's a very, very standard operation. It's been done for many decades. And in the last decade, we've learned to be able to do this operation quite effectively laparoscopically. So that whereas in the past, with a big incision, patients would have to be in the hospital a few days. Now, most patients with a Nissen fundoplication that's done laparoscopically really only require 1 day in the hospital.
Now, what happens with this post-op? Do they do well within 2 weeks, 6 weeks, 6 months?
The results from surgical therapy are immediate. They obviously, you've created a new valve, and the only problem with the surgery is if you make the valve too competent. And so obviously, if it's too tight or not constructed correctly, or if you made the wrong diagnosis and the esophagus doesn't work well, then patients are going to have trouble swallowing because things are going to get stuck at the wrap. And the other thing is, if you make it too tight, you're not going to be able to burp. And burping is a very important function because we're swallowing air all the time. And so those are the two major complications you worry about in doing so-called wraps. One is causing dysphagia or trouble swallowing, and the other is causing what we call gas bloat syndrome, where you can't actually burp.
So if you cannot burp, then all the gas stays in the stomach here, and then does it pass through the intestines?
It does pass through the intestine. People feel chronically bloated. It's an uncomfortable feeling.
Is there medicine to treat that?
Not very effective medicine, actually. Gas bloat syndrome we would consider a failure surgical therapy. We really do not want people to lose the ability to burp, because that's an important physiologic function.
Now, what in the wrap, how long is this operation good for? Forever?
Forever. And
That's
so,
good.
yes. And so there have been some studies in the past that have demonstrated that having a surgical wrap, the old-fashioned way, was actually more cost-effective than medical therapy for the long-term management of reflux disease. So if you have a young patient with significant reflux disease, and let's say they have esophagitis, then they are the best candidates for this type of surgery, because once you've had the surgery, you've addressed the underlying problem, and you don't need to stay on acid suppressive therapy.
Now, what are the pros and cons of this? Some people may feel that they don't want to have the surgery because it takes, it's too painful post-operatively, or what happens?
Well, it is an operation, so it has risks associated with it. And anytime you operate, you have the risk of anesthesia, and modern anesthesia these days is very safe. There's always problems with potential bleeding and infection. That's pretty uncommon in this operation. It's usually very straightforward. As I mentioned, most of the time this operation can be performed very effectively laparoscopically with just 5 small incisions on the upper abdomen, and really a very short hospital stay. And so it's on a relative scale, it's on the very safe side of upper gastrointestinal operations that we do.
Now, you mentioned that another site of problem could be that the stomach just is not competent, and
Correct.
that's why they have reflux problems. Now, show us what you do for that.
Well, that's a bigger problem. The most common patients who have what we call gastroparesis, where the stomach doesn't empty, are actually patients with diabetes. And it's not a very simple problem to manage. Some patients can be managed with medical therapy. And in fact, some patients do well with fundoplication, because reducing the overall size of the stomach by doing the wrap seems to improve gastric emptying in some patients. But you want to know that ahead of time so you can prepare the patient for the types of potential failures that you might have.
Now, tell us a little bit about the pump. If the pump doesn't work, is there any treatment for these people?
Not good surgical therapy. There are diseases such as diffuse esophageal spasm, where the propagation of the peristalsis is poor, and you can actually treat that medically effectively quite often with just medication that will relax the muscles. And sometimes you can do operations for it, but it's fairly uncommon to have to operate for that. What you don't want to do is jump to surgery without a full evaluation. And the full evaluation includes an assessment of esophageal motility,